Okay, so I think we can get started. So, hello from Portugal. My name is Ana. I'm the clinical practice specialist from Sensing Future Technologies. And I want to thank you again for being here and for taking interest in this webinar. So my role here in Sensing Future is to help develop our devices in accordance with the more recent scientific evidence and in accordance with the reality of the clinical practice work, because I've been there and I know the struggles. I also help I try to help our PhysioSensing users to make the most out of their PhysioSensings. And yes, so today I'm going to be presenting you a case study report titled Assessment and Treatment of Balance Dysfunction Using a Pressure Platform and Visual Biofeedback in a Patient with Chronic Stroke Sequel. This work was conducted in collaboration with Dr. Nuno from the Family Health Unit, Fernando Namora. And so this was teamwork, okay? Let me show you the workflow or the presentation flow. I will start by introducing you the case, our patient. I will show you part of the intervention, some exercises that we chose and why. Then we are going to move into the results and into the discussion of the results that we got, and then the conclusions. Okay, and at the end, I have a little surprise. So if you stick until the end, you will see it. Okay, so let's start with the case presentation. So our patient is a 67-year-old male who suffered an ischemic stroke in November of 2020. After the stroke, he developed right side hemiparesis with muscle strength grading of 4. So it's not that bad. It shows some alterations in terms of gait analysis, in the quality analysis of the gait. So we see this patient not having any waist dissociation, walking with short steps and with a very large base of support. Okay. So for a more complete characterization of the patient, so we applied the following scales. These scales are part of the geriatric assessment tool from the Portuguese Internal Medicine Society. And so, for example, let's look into the results. We see the results from the geriatric depression scale. Scores suggested the presence of a mild depression. The CATS index of independent inactivities of daily living and the Brody instrumental activities of daily living scale. So these two reports, these two scales, the scores suggested normal function. One very important factor here is that our patient has had and has a lot of support from his wife in the daily life normal activities. And so this is a big difference in terms of his functional level, because his wife helps him a lot. Then the functional ambulation category characterizes his ambulation has, so it could ambulate independently on level surfaces, but required supervision to navigate obstacles. And this was something that was also very notorious, that he could walk safely and independently inside of the family health unit, but outside he required physical support from his wife. He could not walk alone, and inside. Stepping up and stepping downstairs, he required at least the support of the rails. Okay, so this is more or less the initial state. And this was our intervention. So we performed 15 sessions of 30 minutes of balance training with our PhysioSensing pressure platform and with the balance software, with the exercises from the balance software. Okay, we conducted an initial assessment prior to the beginning of the intervention, balance assessment, and at the end. Okay. So our balance assessment. So we use the Berg balance scale as a clinical balance assessment. And for the posturography analysis, we use the limits of stability protocol, the sit to stand protocol, and the fall risk protocol. Okay. Now I will try to explain you why we chose these protocols and how they are performed and what we can take from them. What is the most relevant information for this case, and to then justify the exercises that we selected. Okay. And so we can start with the sit to stand protocol. Okay, so we chose to use the sit to stand protocol for assessing dynamic stability while performing this movement of transfer from the seated position to a standing position, as it constitutes a fundamental ability of daily life, and that correlates with autonomous living, the ability to safely and efficiently stand up from a chair. Okay, so the measurement of this protocol with a balance enables an objective analysis of the entire movement. So we can divide the movement in 3 phases, and these are the 3 phases that then are analyzed on the software during the assessment. So the first phase is the transfer of the weight of the center of pressure from the chair to the center of the feet. Okay, so is this flexion momentum just before the initiation of the extension. Okay. Then we go into the rising phase, so the complete extension. And the third and the last phase of analysis is the stabilization phase. That is also very important, okay? So after we perform the complete extension, we have to slow down and we have to stabilize our body for then being able to safely start the following tasks, such as reaching for grabbing something or just for starting to walk. Okay, so this is the logic of the phases, the division of the movement in these 3 phases. Okay, so now we can look to the graphic. This is a typical graphic from the protocol. It is a weight variation graphic. On the and I also need to explain this because this is going to be part of our results. So on the bottom axis, we have the time of the test, okay? And on the vertical axis, we have the weight that the patient places on the platform by each one of the legs. So the blue line represents the left leg and the red line the right leg. Okay, and so what we can see is how much weight is placed by both legs during the entire movement. So here, this gray area represents the first phase, this transfer of the center of pressure to the center of the feet. Then we have the rising phase, and then we have the stabilization phase. Okay, and so we can see how much weight is being exerted, or how much force is being exerted by each leg, and we can see if there is a big asymmetry of weight where it happens, if it happens more during the rising phase, if it's more notorious during the stabilization phase, or if it happens during the entire movement. And we can also understand how stable the person is by looking for abrupt weight shifts. Okay, so for example, this is not the graphic from our patient. This is just I don't even know where this graphic is from. If it's not from this patient, it's just to show you. We can see, for example, here that we have a big weight asymmetry, and this is more notorious on the stabilization phase. Okay, but the patient is quite stable. Okay, you will see. You will see the graphics from the patient very soon. So how we perform this protocol. So this protocol has 3 trials of 15 seconds. The patient has to lift from the chair as quickly as possible after the software commands, and it has to stay as still as possible after the complete extension until the timing of the protocol ends. And then he has to repeat this for the second and for the third trial. Okay. So, what are the parameters? What do we measure? So, we measure the weight time transfer, so the time of that initial phase, the time between the indication to get up and the arrival of the center of pressure here over the feet in seconds. The rising index is a very important parameter because it's a measure of strength. So the meaning of this parameter is the force that is exerted during the extension, during the rising phase, and is expressed as a percentage of the body weight. Then we have the sway velocity, which is the velocity of the center of pressure during the rising phase and during the stabilization phase. And for our patient and for patients with hemiparesis, this parameter, the left-right symmetry, is very important to be analyzed. So the meaning is it's the percentage of weight difference between the right and the left leg during the rising phase and during the stabilization phase. Okay. And here we have the results from our patient from the initial assessment. So prior to the beginning of the intervention, so we see immediately see that we have a big maximum differential. This is something that in the other graphic it didn't show. It is this green line. So it's the biggest difference of weight, and we can see where it happens. So we see a big difference of weight, a big asymmetry of stance during most of the movements. We see that is very unstable. So we see that the patient is always shifting, doing abrupt weight shiftings. So this is only in the medial lateral plane. The first one is not that bad, but then the second and the third one is quite notorious. We also see that we have a tendency towards having more weight placed on the left side. Okay, so this makes sense because it has right hemiparesis on the right side. And we see that here, the weight time transfer, this gray area, it's quite large. So it means that the patient took a lot of time during the first phase of the movement. Okay, and these are more or less in accordance with the research that is available, that assesses stroke patients and with this protocol. We see almost see an asymmetry of weight bearing during the entire movement. And so because of this, we decided that we should use exercises with visual biofeedback that could inform the patient on the amount of weight he has in each leg, even during the sit to stand, and for him to try to distribute the weight more evenly. And then you will see it. I will show you some clips. Okay, so the limits of stability protocol, also a very important protocol, and one that it can be used for many different clinical contexts. Even for the assessment of the elderly, for assessing fall risk, it is a very important protocol. So the limits of stability is a concept that is defined as the maximum distance the person can displace his center of pressure by leaning the body, okay, within the base of support, and of course without losing balance. But very important, the movement happens only here in the ankle. So we are talking about the ankle movement strategy, okay? It's similar to an inverted pendulum. I don't have a pen here, but it's this kind of movement. Of course, we have a limit of maximum displacement. Yeah, so we have more or less 6 to 8 degrees of range of motion to the front, 8 degrees to the sides, and 4 degrees to the back. And this area that is limited by the range of motion is called the cone of stability, or the stability area. And this is also a very important concept because and thinking about proactive balance, having a correct internal representation of this area of stability allow us to activate the correct muscle synergies and the correct movements to control our center of mass within this area. And this is the beginning of most of our daily life activities. Every time we want to grab something, every time we shift and we turn, and even during gait, we need to be able to transfer our center of pressure, our weight, from the ankle in the anterior and diagonal directions. And so we are here talking about being able to assess how a person initiates voluntary movement and how a person controls that movement. Having a decrease in the limits of stability in this stability area, or having not I do not say realistic, is not realistic the word that I want to say, but having a bad representation of having a bad internal representation of this area can have a big impact on how a person can safely perform normal daily life activities and being at risk at falling more frequently. Okay, and this is of course very important for assessing balance, proactive balance in stroke patients. Yes. Taking into account the frequent dysfunctions that we see. Okay. For the parameters that we analyze, but before that, I need to explain you the main goal of this protocol, because this is a frequently asked question. The goal of the protocol is not to achieve the targets. The goal is to displace the center of pressure at the maximum distance towards the target. So the maximum point towards the target, to go as far as possible towards the targets, not to achieve the targets. So it's not a pass or fail test. It's let's see how much you can displace your center of pressure towards that target. And so this is something that we need to explain to the patient, because then the patient will feel like he's not able to complete the protocol, even as we will think that something is not right. But no, it's just the goal is to try to do the best the patient can. Okay, so we start in a center position and we displace the center of pressure, our body, towards 8 different targets. Okay, and then the protocol and then the software calculates all these 5 parameters of analysis. So we have the reaction time, which is a time between the indication to move and the initiation of the movement. The endpoint excursion is the maximum distance we got at our first try. Okay, and then we adjust something in the movement, the velocity, the direction, and we got a little bit further, and that will be the maximum excursion. It's the difference between these 2 points. The endpoint excursion is the first try. The maximum excursion is after correcting, changing something on the movement. We then were able to go a little bit further, and that point will be the maximum excursion. Then is the movement velocity. So we want the movement to be fast, so but controlled. We have to also say this to the patient. And direction control is also a very important parameter. It's a measurement of motor control. So it will measure the amount of movement that happened in the wanted direction. So if you draw a line from the center to the target that we want to achieve, the software will calculate the amount of movement that happened on top of that line. Okay, so it's a measurement of direction control, of motor control. Okay. So now let's see the results from the initial assessment from our patient. So we see here the graphic representation that we always get when we finish the protocol. So it represents the displacement of the center of pressure towards the 8 targets. Okay, so what we see here immediately is that this patient has very reduced limits of stability, and that it's way more notorious towards the right side. And remember, it has right hemiparesis, so it's more or less expected. Okay. These are the results that the software, the report that you can get with the report. And I'm sorry, the titles are in Portuguese, but I will translate it at the end of the presentation when I'll show you the comparison of the results. It will be in English. It's just these ones. So we see here, because we are talking about maximum and endpoint excursion. Here, this one is the endpoint excursion, and this one is the maximum excursion. And we see that we have low values of endpoint and maximum excursion. And yes, it's significantly worse to the right side. This is right side, this is left, this is right, this is left. Okay. Another information that we have, so this is the direction control. Okay, so we see low direction control, except to the back direction, and this is the same for the endpoint and for the maximum excursion. We have also a slow movement, with exception from the back movement, and then we have the reaction times results that they seem too good to be true, and I think it is too good to be true, because this is not an easy protocol to perform, and usually it's needed to perform a training assessment before the real assessment. And so this is what we did. We performed a training assessment protocol, and then we performed the real assessment protocol. And we think that the patient was anticipating the initiation of the movement, because these results are very, very good, and they are not not what we would expect. And while we analyze the other parameters, it does not make much sense. And so this parameter is the parameter that is influenced a lot by psychological and cognitive factors, such as anticipating the movement, because he knows he has to go fast, and the person tries to start immediately the movement. For at the opposite side, for example, fear, anxiety, that make the reaction time longer, lack of attention, focus. So it's a parameter that sometimes it's difficult to understand the result. Okay. But also, these results are in accordance with what we see in research. And so, because taking into account these results, we decided to perform exercises to train weight transfers in every direction, and exercises that stimulated direction control. So that challenged motor control also. Okay, and as for the static analysis, we perform the fall risk protocol. So this is a static balance assessment. We assess balance in 4 different conditions. The first condition, the patient stands on top of the platform with a normal stance, with eyes open. The second condition, the normal stance again, but the patient closes his eyes. The third condition, the patient joins the feet, so acquires a narrow stance and maintains his eyes opened. And the fourth condition, we have the patient in a narrow stance with eyes closed. Okay. The main parameter of analysis is the sway velocity index, which is a parameter that is based on the medial lateral velocity. Okay, and high values are suggestive of postural control deficits. One limitation that we have on this protocol is that it only takes into account the medial lateral velocity. It means that we do not know what is happening or what has happened in the anterior postural plane. So we don't know if the patient is having more sway on the anteroposterior plane. But yeah, this limitation that we have with this protocol. The results are quite good. This is something that can happen, and that's why I always recommend the use of a functional assessment and dynamic assessment, because the deficits will be more notorious in an assessment of the volunt of dynamic balance, of proactive balance, not much more than in just a static analysis. So if we only use the static analysis, we may miss some things that are important for the patient. And we are, for example, for the sit stand is a functional movement. The limits of stability is fundamental for daily life. So I always recommend to use at least one dynamic assessment. Okay, so we have good results here of static balance. We don't know what is the stability level of the patient in the anterior and anteroposterior plane. Okay, this the limitation. Yeah. So for this reason, we decided that we would use mostly dynamic exercises. And we used exercises to train weight transfers in every direction, to train direction control, and to stimulate a more symmetrical weight bearing, specifically during the movement, the sit to stand. Okay. I want to start by showing you our warm-up exercise. For the people that are here that already worked with PhysioSensing, this is my testimonial on this exercise. For this patient, I discovered that this exercise was fundamental for being able to perform the rest of the exercises correctly and to take the most out of the session. Okay, so this is a very simple exercise that only works the weight transfer on the interior and anteroposterior plane. Okay, the patient has a visual biofeedback of the percentage of movement that is performing in this plane. And so I would ask the patient to feel the weight going from the heels to the toes and the toes to the heels, to give some stimulus to the mechanoreceptors of the sole of the feet. I don't know if I mentioned this, maybe I forgot, but it was on the slides, on one of the first slides. This patient was diagnosed with diabetes, I think 30 years ago. So we have to work proprioception with him, and we have to work on the stimulation of the mechanoreceptors from the soles of the feet, and also the ability. This allowed the patient to gain more confidence on his movement and on the control he had on the center of pressure, on the center of mass. The visual biofeedback helps to guide the movement and to motivate. And also, this exercise also helps us to work on the intrinsic muscles of the feet, so to work on toe strength to control the movement. Another game that we performed almost every session was the BART game. I wanted to show you this game because it offers a lot of different therapeutic challenges, and for this patient, they really fit what we were trying to achieve with the intervention. Okay, besides the therapeutic and the physical challenges, it's a very engaging and fun game to play, and so the patient could play an entire game, so it's 4 minutes, and then repeat it, and you would not be tired. But for some other exercises, you would have to rest more frequently. So it was having fun, and it was getting motivated with the game. Okay, so I can show you here some clips. So here, the patient has to transfer the weight to the right to lift the left leg and to avoid hitting the bars. Okay. So I always had my hands on the patient to guide and help, specifically for achieving a unilateral stance. This is the continuation. Okay, so now the patient has to keep a centered position and maintain it to be able to cross the bridge without falling into the water. Okay, now he has to quickly transfer the weight to avoid hitting the obstacles and to collect coins. So it's more rapid reflex weight transfers. And this is the continuation. And I just wanted you to see the finishing line because it was important for the patient to get to the finishing line. Yeah. Okay. So if we have some screenshots of these these challenges, so the first one is the patient has to quickly transfer the weight to avoid hitting the obstacles. Here, he has to transfer the weight to the left leg in order to remove the right leg from the platform and achieve a unilateral stance and avoid hitting the bars. Here, he had to transfer the weight and maintain the weight on the left side to be able to cross the bridge and collect the coins. And here he has to remain with this weight equally distributed, so in a centered position to go towards the bridge and to cross the bridge. Okay. So the exercises that we chose to train weight transfer, we chose exercises that worked on rapid or weight transfers, on more controlled movement. Sometimes we used, and this is an example, these exercises where it is required for the patient to draw a figure with the center of pressure are very good exercise to train and to stimulate motor control. So the ability to perform those weight shifts, those weight transfers, and maintain the correct trajectory of the movement. We also use these exercises a lot. This is an example of one where the patient had to draw a square with the center of pressure. He had some troubles on the corners. Another important aspect is here, these parameters. For example, here the limits. We placed the limits at 30%, taking into account that his maximum excursion was around that value. So we did not want to work much below that, but we also did not want to push too hard. So it was it fitted the patient ability to do the exercise. So here we have visual biofeedbacks for stimulating more symmetric weight bearing or symmetric stance, and we use this for the C2 stand. I have here also a clip of me performing these exercises. All of these exercises were exercises that we perform with the patient. So this is the warm-up exercise, the one that I was saying that I really liked. And it seems very simple, but it was so efficient for the patient to understand what it was meant to do, and to gain confidence during the movement. Here is for training the sit to stand and a more symmetric weight distribution. Okay. It's very, very, again, so very simple, but efficient. Okay. Here we have toe rises and heel rises, and this was good for me to see how much weight it could remove from the heels specifically. This is a good exercise to train direction control and the weight transfers. Again, all the parameters, the limits are set to work in accordance with the patient abilities. So here we have to quickly transfer the weight to validate a dot and stand on top of the dots at least for 2 seconds to validate it. It's not much for direction control, it's more for quick weight transfers. Also a very simple exercise, but the patient has to react to the movement of the ball. We can increase and decrease the velocity of the ball and the size of the bar. Okay. Again, more quick weight transfers. This is also a different game that we use. So here the patient has to control the ball with weight transfers within different planes of movements in order to go to till the finishing line. Okay. And now I can show you the results. Okay, so let's see. Here we have and you already saw, the graphics, the weight variation over time graphics from the initial assessment, and here from the last assessment. Okay, so we already see big difference in terms of weight asymmetry. We really did target. We also see here a decrease in the weight time transfers. Looking into here the gray area compared to the ones above. The only that didn't go as good was the third trial here, where we see a lot of instability. So I don't know if he was tired. I don't know. This one didn't go well, but these two are already much better than the previous ones. Okay, but now let's look into the results. So after you perform a reassessment, the software generates a progress report. Okay, and so you see the green bar is the results from the initial assessment. The blue bar is the results from the more recent assessment. And you see a percentage of improvement here below the bars. And each parameter has his own graphic. So we see that for the weight time transfer, we see that the patient improved in 20%. So it was 20% faster to transferring the weight to the center of the feet to initiate the movement. For the rising index, this is amazing. The patient improved 60%. So he exerted 60% more force on the platform when compared to the initial assessment. For the left-right symmetry, we got a 50% of improvement. So we see that the patient achieved a 50% more symmetric weight, more symmetric stance during the rising and the stabilization phase. And here, this is the only result that didn't get better. It is the mean center of pressure sway velocity. So the sway velocity of the velocity of the center of pressure. I believed because the last trial, the third trial, it was very unstable, and I think this slight difference may be because of that third trial, but we don't know. Okay, but still we were very happy and quite surprised by the percentage of improvement that the patient achieved. Okay, now the limits of stability. Okay, so we can already see big differences in terms of maximum excursion. We see that the patient significantly increased his limits of stability. Okay. We also see the same graphics for this protocol. So here, the only parameter that also does not make much sense is the reaction time. Again, such as I said earlier, we think that he was anticipating the movement, not as much as on the reassessment, but sometimes also, for example, here for the back direction. These results are very inconsistent and inconclusive. We cannot draw any conclusions from this. Okay, but let's focus on what we can understand. So these are the results from the endpoint excursion and the maximum excursion. We see that we improved in 100%, the endpoint excursion here is the average, the composite for every direction. The endpoint excursion, and in 90%, the maximum excursion. So these are significant increments in the limits of stability. So, and remember, decreased limits of stability are associated with a higher risk of fall. So it's very relevant. Another suggestion for the people that already work with PhysioSensing, I always like to analyze these two parameters together, the movement velocity and the direction control. Yeah, because we know when we change velocity, the quality of the movement can also change, and frequently does. And so I like to see them together. And also we have very striking results here. We have an increase in 100%, 140% of the movement velocity on average, and we also got an improvement on direction control. So we improved 100%, 140% the velocity of movement, and we did not lose the quality of movement. The patient could improve the quality of movement, the control of the direction of the movement, even by increasing the velocity at this level. And so this tells us a lot that this tells us that the exercises that were performed really did target fundamental aspects of direction control, motor control, weight transfers. So they are very satisfactory results for us. The fall risk protocol, we also got a slight improvement as well. In average, a 10% of improvement on the sway velocity index. For the comfortable stance, we have 20% of improvement, and with a narrow stance here with eyes open, 10% of improvement, and no improvement with eyes closed. So again, I think that it's always good to have a dynamic balance assessment, because it will make us see deficits more clearly, and then also to understand how the patient is progressing in a more notorious way. Yeah, so this is just a shy improvement. Okay, I'm always at the end. I'm sorry. So here we have other results. Okay, so for the Baird balance scale, we got a difference of 8 points, so increase 8 points the score of the Baird balance scale, which is also already good. And what is interesting here is the results here on the geriatric depression scale, where we got an improvement on the state of emotion. So we move from having a 6 points, suggesting the presence of a mild depression, to 4 points, so with no depression as suggested. So here we think about the topic of gamification in physical therapy and in rehabilitation. We know that the appeal, the motivation, the fun that is associated with games are connected to reward-related dopamine systems, and that these systems do support learning processes by forming long-term neural connections. That, of course, it will help a lot in neurological recovery. But mostly, or maybe the most important thing is here the adherence to the treatment, and the patient feeling motivated and having a good time with the training sessions. Okay, so this is also already well studied, and I think it's a very important topic nowadays. Okay, so as a conclusion, so these are the main topics of improvement. So we improved the weight transferability, which consequently led to an increasement on the limits of stability. We improve motor control, specifically the direction control, and we achieve a more symmetric weight-bearing stance during the sit to stand. We also improved the strength exerted during the sit to stand is not here. So we are very happy with the results. I think the intervention went really well. This is just a case study. We hope we can replicate it with more patients in the future. I want to thank Fernanda Mora Family Health Unit for the collaboration, and I want to thank Dr. Nuno for the collaboration as well. And I want to thank you for attending and for sticking here. And now this is the surprise that I told you at the beginning. So until the October 4th, we are going to have a 10% off only here. Only for the 3 Rehab solution, which is the pressure plate, the one that we used with the patient, with the balance software, the software that we used, plus a software for podometry, so for plantar pressure distribution analysis, for gait analysis. So it's a more complete package, let's say. So thank you. We are going to release an ebook with this case. We already have an ebook available for free download. We also have small articles available on our blog, and we have all the previous webinars available on YouTube. Okay, so you can follow us on our social media, and you can contact me here. I have my email. Any questions, any topics that you want to discuss, or if you are interested in knowing more about our platforms and our softwares, you can contact me. And yeah, so now we got to the finishing line. Thank you again for being here. I hope you like it, and I hope if you are already using the PhysioSensing that this might be a helpful training session, let's say. So thank you, and see you on our next webinar.